Hi everyone. I wanted to show you this study that has some interesting elements in it. Some bread and butter stuff that I hope will be useful to you. Here is this is a gentleman that came in, 87-year-old, coming in with shortness of breath. This is so I always say you can see a lot from an initial parasternal long axis view. So here's a parasternal long axis view, and what's interesting here, what I will point this out, that this is a artifact line here, most likely a reverberation artifact coming from the pericardium. A very highly reflective surface, such as the pericardium, can also cause a reverberation artifact, which we'll talk about it at a separate time. So that's a very good example. And one clue is it's moving exactly in synchrony with the pericardium. Another thing to mention, that I do see a fair amount of a pleural effusion here. This is the left pleural effusion. The left atrium is very sizable. There is a significant calcification at the mitral valve annulus, and as well as the tips. There is some calcification here in the aorta as well. The aortic valve seems to be opening fairly well, and the a brief look here, the RV does look a little bit thick, but looks normal in size and looks like it's contracting. So I always tell the fellows, when you're first looking at a echocardiogram like this, that in the first shot you should be thinking about what are your focus points on this echocardiogram. So I'm already seeing that the LA is huge and the mitral valve is pretty calcified. So my focus points are going to be whether or not there is mitral stenosis, possibly there's some calcification there, or mitral regurgitation, which is a more likely scenario in this case. Going forward, here is the aortic valve in long axis view. It looks like it's opening well. There's some calcifications, however. And moving ahead to the mitral valve here on long axis view, calcified, opening well. The posterior leaflet does look a little bit restricted. And here is the mitral regurgitation. I always find that the parasternal long axis view often underestimates the severity of the regurgitation, so I anticipate that it's going to be actually a little bit more later on. The vena contracta is now estimated to be about 6, which is a roughly moderate range. The regurgitation jet giving a TRV max of 403, which is high, and a max gradient of 65. So assuming an RA pressure of about 8, which I think this person would be, at least you're looking at a RA PISP of about 70 or higher. LV looks like it's contracting well. So here is your LV, here's your papillary muscles, the posterior medial anterolateral. Moving on, here is the aortic valve on short axis. There's some trace amount of aortic regurgitation, but not very much. The aortic valve also appears to be opening very well with some mild calcifications at the edges. Here's a tricuspid jet again. Here we're getting a slightly lower velocities here because we're not quite on axis as we were before, but I do believe that there's very severely elevated tricuspid pulmonary hypertension. Numbers over 55 millimeters of mercury would be consistent with severe pulmonary hypertension, and here it's going to be 75. So this person does have severe pulmonary hypertension. There's a fair chance that it may come from either diastolic dysfunction or more likely from the mitral regurgitation that has been occurring. So here is the 4-chamber view. And here is a very impressive mitral regurgitation view, jet. One of the things I always teach the fellows to look at is to look at your Nyquist limit. Here we have a pretty big color window. You see the jet pretty well, but whenever you have a big color window, you run the risk of having your machine automatically turn your Nyquist limit pretty low. Most of the color images, color calculations that we get based on echocardiogram is based on a Nyquist limit of 69, which is very hard to get. Very often we're getting numbers in the 50s. So the lower your Nyquist limit is set, and this is just a function of the machine automatically setting the Nyquist limit for you, depending on how big the color window is and how much information you're asking it to get. So now it's set at 59, so it's a little bit low. Whenever you have a low Nyquist limit, you worry that you're blooming your color jet too much. So and I encourage you to try this. If you just go ahead and lower your Nyquist limit next time you're scanning, and you'll see that the color jet goes starts to expand more and more. 59 is fair, and I think this is the fair jet to be assessing mitral regurgitation. The regurgitation jet does reach the posterior wall. It looks like it's central in nature, and I'm going to be calling it severe. LA volume in 4-chamber view is 131, which will come out to, and this will index to be about 80, which you'll see a little bit later on. So that's consistent with severe mitral regurgitation. Here, the vena contracta is measured to be about 7, which would be considered severe. This is mitral regurgitation, MR jet, very solid, very filled in. Velocities across the mitral inflow are high, 207. I think this is more likely than not due to the high regurgitation, the very severe mitral regurgitation. The LV appears to be contracting quite well, so the LVEF is pretty high, but just be careful in the setting of a mitral regurgitation, your actual stroke volume, and it may actually be low because probably half of it, if not more, is actually coming backward through the mitral regurgitation. In the cases you see after mitral valve repair, if somebody did like this does end up getting a repair, you'll see almost immediately that the mitral, that the LV function kind of goes lower, because the LV is no longer pumping into the LA, it's just pumping it's strictly into the more into the LVOT. So very common to see after mitral clip or after mitral valve surgery for mitral regurgitation that the LVEF actually goes down. So here's a little bit of AI, not much of a jet to be able to calculate with. 2-chamber view, anterior wall, inferior wall. Again, there's a very nicely contractile LV, except there's severe mitral regurgitation. Indexed LA volume is 82, so that's consistent with severely dilated left atrium. Here's the jet again, mostly central. There's one view here where it actually looks like it may be a little bit posterior. So this view worries me a little bit. It actually looks like this jet is going into the posterior wall and wrapping around. Again, we have to be careful when we're looking at it because our Nyquist is now 56 to 60, which is okay. I think it's fair to judge from this jet that there is severe mitral regurgitation. And here is the subcostal view, and there's no PFO going from the left to right, seen with echo with a color contrast. There's tricuspid regurgitation, which on this view actually looks pretty mild, but I believe it's probably pretty severe based on the previous views. Mitral regurgitation likely underestimated on this view. The IVC is surprisingly not huge, 1.6, and it does look like it's collapsing, but less than 50%. So I would give this RAP about 8 millimeters of mercury. So I hope that was helpful to you.